Hello everyone. Thanks for being there. We are now in our weekly session of Virtual Global Spine Conference. I'm Alfredo Giroy, and I have the pleasure today of having Cristiano Menezes. He's a very close friend of mine, and he's a worldwide recognized spine surgeon. He focuses on minimal invasive spine surgery. He's the past president of the Brazilian Spine Society, and he's actually the chair of education for AO Latin America. So without further introduction, hi Cristiano, thanks for being with us today. We for sure will learn a lot today.
Hi Alfredo, hi, how are you all? Good evening. It's my pleasure to be part of the Virtual Spine. I'm so honored to be invited, and let's play this talk and having time to discuss a little bit about the topics about single position surgery. May I start, Alfredo? So I'll share my screen.
Yeah.
Just 1 second, please. Oh, position. Okay. There we go. Can you see my slides, please?
Yeah, perfect.
Okay. So starting with single position surgery, it's a hot topic, in my opinion, something that it's extremely useful for the modern spine surgeon to deal with daily cases, to deal with routine cases, patients with degenerative conditions that you have to approach, especially the lower lumbar spine. So that's the reason I changed a little bit the title of this presentation for single position anterolateral for L4S1. And the reason for this is that here, my disclosures, just holding a little bit for you guys to check on adequately. And how many of you face this type of situation every day in your consultations, in your office? A 77-year-old lady, 2-year postoperatively, posterior approach from L4 to S1 with TLIF, and the patient had a breakage, an adjacent level disease in L3, L4, in a very short post-op period with a spondylolisthesis who needed reconstruction, in this case, a 2-level ACR, but anyway, it could be a PSO or other technique. But the reason is the patient lost in a degenerative, simple, routine case the chance to restore the base of the lumbar spine. So the most important levels to get restoration. We're gonna summarize this presentation, defining what's single position surgery, discussing the importance of sagittal alignment, especially in the lumbar levels, and outline the steps to perform safely tristic reconstruction using single position surgery. So as the main author of this statement, my friend Alfredo and the team, single position surgery is any procedure in which you approach the spine both from anterior and posterior without changing the patient's position. And we're looking for efficiency, safety, because you decrease the surgical time, the use of anesthetics, facial and pulmonary risks involved with the prone position. We look for feasibility with time savings, and why not to talk a little about cost, especially during using disposables, because you take out the flip factor from the procedure. We do know as spine surgeons that we have many options to fuse L4S1 and other lumbar levels as well, but especially the lumbosacrum junction, we can use posterolateral PLIF, open, or MIS, TLIF, ALIF plus lateral transpsoas or anterior psoas anyway, but usually all the techniques are good. The problem is not about the technique, but the surgeon who's performing the technique or the choice of the right technique for that specific patient. I like this Cedric Barret paper. It's very, very informative, very classic to show that situation that we were discussing before. That is, we have a possible lateral fusion or a TLIF between L4S1, where the surgeon had lost the chance to restore the lumbosacral lordosis, and the level above in L3, L4 works as an open fish mouth, trying to restore or trying to do the lordotic segment that has been lost in L5S1 especially. And why I go anterior and lateral for L4S1 fusion? The reason is, I mean, for routine degenerative cases, is definitely the best way to perform, to gain time, efficiency, and to maintain the lumbar lordosis when we need fusion on these levels. We can, for sure, we can do more than 2 levels. We can do L3S1, we can do L2, L5, we can do any segment of the lumbar spine. But to be honest, I think that the degenerative cases are the best for do this. I'm not trying to convince people to treat deformity, adult spinal deformity, or more complex situations using single position. But in the routine cases, when you have to approach 5-1, especially in more than 60% of the cases, this is a good way to do it. We know that all the importance of sagittal parameters, these parameters were popularized by Frank Schwab after his publication talking about SVA, PT, and the mismatch between lumbar lordosis and pelvic incidence. But we know that the rule is not that simple, because SVA doesn't account for compensation. So we have a patient with a large compensatory mechanism doing retroversion of the pelvis, and it's not far from 5 centimeters of SVA. The PT below 20 degrees does not account for pelvic incidence. We know that 19 degrees can be horrible for a low pelvic incidence patient, but can be completely normal for a 80, 75 pelvic incidence patient. And finally, the mismatch between lumbar lordosis and pelvic incidence does not account for something that is unique and important in terms of importance, the distribution of the lumbar lordosis. So we know the 4 types, the Russell-Lee types, that we have low-grade pelvic incidence, which is represented by the description of Russell-Lee of a sacral slope below 35 degrees, type 1 and type 2. We have the type 3, the more harmonious lordosis, the more harmonious spine with a moderate lordosis, with a sacral slope between 35 and 45, and you have a type 4 with over 45 degrees of sacral slope, which means that the type 3 and type 4 are high-grade pelvic incident patients. But what we need to know is that the lumbar apex shifts cranially as PI increases. So for Russell-Lee type 1, the apex of lumbar lordosis is over the L5 vertebral body. For type 2 is in the disc of L4-5, and then type 3 over the vertebral body of L4. And in type 4, the apex of the lumbar lordosis is on in the disc L3, L4. So depending of the low-grade pelvic incidence, high-grade pelvic incidence, we need to address the lordosis in the right places. That can be L3, 4, 4, 5, and 5, 1, or can be just 5, 1. But in any way, in any patient, L5S1 is the critical level to restore lordosis. Doesn't matter if you're facing a low-grade or high-grade pelvic incidence. So as we were discussing, 80% of lumbar lordosis is in the lower lumbar arch, which means L5S1 basically, in type 1 Bruce-Lee, 70% in type 2, 60% in type 3, and 50% in type 5, type 4. So the conventional three-column osteotomy, for example, at the level of L3 and the level of L2 works or can work better in patients that the upper lumbar arc is representative, and can be really catastrophic in patients where the upper lumbar arc is minimum or very low. And there's no way to restore lordosis in the lower segment different than to put a cage, an interbody cage on these spaces. So in a low PI patient in L5S1, or performing a PSO at the level of L5. Besides of that, in a high PI patient, you have to use the L4S1 segment to put cages or to restore lordosis doing PSOs in the lower levels. And this is quite critical because perform PSOs, this is a very critical operation, it's very useful, but for rigid spines, it's not routine, it's not the best operation to do in mobile segments, especially in lower levels, because the difficulty, the technical challenge, it's very important. And finally, the GAP score was introduced to treat adult spinal deformity patients to study this type of population, but we can have the same orientation, especially to avoid iatrogenics, because as we know, the two main reasons of adult spinal deformity are degenerative conditions over time and iatrogenic. And iatrogenic means that we, as spine surgeons, we are creating deformity. We are creating deformity, and we've been creating deformity for the last decades, where spine surgery exploded in the last 20, 30 years around the world. And many of the deformities we're facing now, they are iatrogenic. This is nice because you have every day different techniques and very interesting techniques, as the prone lateral, which is a way to perform single position surgery, but with the patient in prone. The reason I don't believe that this technique is fantastic, it's very useful, but for specific situations, as for example, adjacent segment disease, I cannot think this technique can be useful for daily cases because you cannot approach 5-1 in prone. And more than this, we need to be aware about the risks of the associated with any new technique. We know that in prone, the distance between skin and the disc space increases in average by 1 inch. And the left column, because of the splenic flexure and the sigmoid flexure, and the white line of Todd. The left column moves posteriorly just in front of the corridor you're working. So this is a very nice technique, but you need to address these issues. At the same time, the importance to approach 5-1. Why 5-1 must be the level to be restored, and why single position surgery in lateral is so important for that. This is a paper just published this month, um, uh, um, last month and last December, I mean, by International Spine Study Group, with a total of 693 patients with adult spinal deformity. As we were discussing here, we're discussing single position surgery in degenerative cases, but the knowledge and the data about this is so important. We know that ISSG has many of the posterior guys doing adult spinal deformity forever. And in this paper, they show exactly that the combining approaches were more effective to restore PT and the gap score. Specifically, anterior lumbar interbody fusion were below L3, demonstrating high rates of improvement versus TLIF to restore Russell-Lee and gap. And finally, they conclude, clinically, patients undergoing in the combined approach demonstrated higher rates of meeting significant clinical benefit in Oswestry Disability Index by 2 years, while minimizing rates of proximal junction failure. So this paper basically is discussing about adult spinal deformity, but even in a group with dominated by posterior surgeons, posterior open surgeons, they recognized the value of restore with ALIF L5S1. That's the reason I do believe that's the best way to address L5S1 is in single position lateral, because you can address 5-1, 4-5 in screws at the same time. And how to address L5S1 in single position lateral surgery? Using lateral ALIF, which has the same indications, limitations, and possible complications of the supine ALIF, maybe with some limitations in high PI patients. So in the major population, patients with PI under 80, 75 degrees is completely feasible, but in patients with extremely high sacral slope and extremely high pelvic incidence, it can be challenged, and has a flat learning curve for challenging situations, and possibly, and some papers are showing this, lesser complications, especially about ileus, because you have less manipulation of the intraperitoneal contents. As you can see here, the gravity works for you. The gravity works towards taking out the abdominal content from the front of the spine. And we had the chance to publish this paper with Kajavi, showing that the radiographic outcomes are quite the same from the supine and lateral ALIF. And even that this technique can be taught, can be learned by spine surgeons to perform in the majority of the cases by their own, or to use your access surgeon as a partner, as you use for the supine ALIF. Here's some technical highlights. I like to show these pictures because I do believe that the systematization of the approach is the key point to achieve 5-1 in a safe way and perform these surgeries routinely. So after opening the rectus aponeurosis, the abdominal rectus aponeurosis, and the junction of the lateral rectus with the oblique musculature, we're going to gain the heteroperitoneal plane, just passing your fingers behind the peritoneal contents, until you find the psoas muscle at the depth of the wound. And this third layer of fat, which I call the third layer of fat, because the first layer is the preperitoneal, the second layer is the retroperitoneal, and the third layer of fat is this one just in front of psoas muscle, when you always will find the ureter. So differently from the supine aleph, due the obliquity of your view, you can always identify the ureter and protect the ureter with the peritoneal sac. Then you're going moving deep. You're going to find the left iliac artery, and behind the left iliac artery, the left iliac vein. I prefer to leave the iliac vein in the same place until I achieve all the exposure to the contralateral side, which means in this case, when you have here the head, here the foot, here the lateral, and here the medial part of their exposure, to keep the left iliac vein in place and identify the middle sacral vessels, the hypogastric plexus, and to keep dissecting from the left vein to the lateral right corner of your disc. Then you keep going, taking out all the areolar tissue over the L5-S1 disc space. And then I use these special retractors. There are many manufacturers, many companies offering this type of retractor. But here, the thing is that the downside retractor is a reversed lip retractor, and then the other is a normal retractor. So you can gain the anterior part of the L5-S1 disc space from the left top corner to the bottom right corner, and to have all the L5-S1 disc space available to put a wide and lordotic spacer in the same way you do routinely using supine aleph. You can also work in two levels, working 5-1 and 4-5. It depends on you. It depends on your access surgeon. I prefer to deal with 4-5 with a different technique. I prefer to use the combination of aleph for 5-1, the level it's safer level for aleph, to use transpsoas for 4-5 or anterior to psoas for 4-5, depends on your preference, and 3-4 and etc. And then to use percutaneous pedicle screw fixation in lateral position to get it. So as you all know, transpsoas is a game changer in history of spine surgery. It's a powerful anterior column manipulation, and it's minimally disruptive. Cannot restore the same amount of lordosis than aleph, but remember that 5-1 is the crucial level. So if I need lordosis, I need in 5-1. In 4-5, if I need lordosis, an extra lordosis for any reason, a type 4 Russell-Lee in a patient with extremely high pelvic incidence, I can use aleph as well. So in a regular patient, in a type 3, type 2, type 1 Russell-Lee, I can use lateral, because it's lateral in lateral has the amount of lordosis sufficient for that segment in general. And more than this in 3-4, 2-3, 1-2, and whatever levels you want to do. Here, just an example showing that neuromonitoring is important. The type of retractor is important. Sorry. The type of retractor is important. The neuromonitoring is important. The retractor time is important, not just for decreasing the risk of nerve injury, which is not in a statement, but it's something that makes sense. but to avoid tight symptoms, because less you retract the psoas muscle, less tight symptoms in the post-op. Definitely, there are many fake news about lateral, as position the patient in a jackknife. This is not useful for the less. If XLIF has 20 years of introduction and description, probably it's been 18 years that nobody does this type of jackknife position, but we can see all these pictures every time during presentations. And if I have a high crest, I can use angular instruments. You can use better instruments to approach the disc, much better than to break the patient's hip in half. And we do have many prospective, randomized, multicentric, many studies to show the quality of this technique for 4-5 and up. So here, one prospective randomized study that my team has the chance to publish in 45 patients, which 40 were in L4-5, mainstay of 1 point something days, and length of surgery of 1 hour and 15 minutes, and achieving more than 85% of significant clinical benefit in terms of ODI, and more than 90% in significant clinical benefit in terms of back pain. And recently, we had the chance to publish internationally in a multi-center retrospective study, the largest cities just focused in 4-5. So it was 7 surgeons. There were 7 surgeons in 3 countries with a follow-up of 5 years. We studied a series of 517 patients and showing how safe the technique can be when the technique is well used, when the surgeon knows exactly what to do, and when the patient is right selected. So we have overweight, as normal, as usual, operative time, 1 hour and 20, 1 hour and a half, less than 2 hours, sorry, and length of stay of 2 days in average. And the most important thing is that we had in these more than 500 cases, 4.8% of neurological deficit, but in femoral neuropraxia, it's just 1%, which means that it's completely acceptable. And with long-term, we had 0% after 1 year, and a little bit more than 6% of tight dysesthesia. So showing that these numbers are completely acceptable, even when you compare with posterior techniques as the TLIF. And more than this, the reoperation rates in 90 days below 7%, and associated with the cage itself, the procedure itself, the transpsoas itself is just 0.6%. Okay, and finally, to finish this package of single position lateral surgery that started with ALIF in 5-1, XLIF, or anterior to psoas in 4-5, 3-4, and above, we finished with percutaneous pedicle screw fixation, which is not a dangerous thing to do. It's not the easiest thing to do as well. We need to use to have some experience to avoid, especially in-out technique, which means passing beside the pedicle instead of inside the pedicle with experience. But it was described a long time ago, more than 10 years ago. And now, facing with all the benefits of using navigation especially, but even robots, we can address this situation very nicely. Can be performed for sure using fluoro, but definitely it's much better to use navigation. It's I think that's these advances in terms of technology is very well accepted. We can also address some direct decompression using tubes in lateral position. It's nothing that can be considered challenge or difficult to, you know, to contribute for you to change the approach or to think that this is not the best approach for L4S1. And we can get nice reconstructions, we can deal with the daily cases, as I said. I'm not saying about deformity, but if you need to do a deformity, you can address all the anterolateral in single position, which means 5-1, 4-5, 3-4, 2-3, 2-3, and 1-2, very fast, and then to flip the patient just once to get in a posterior approach. So as take-home message, I think that L4 segment is crucial for sagittal alignment. A fusion procedure in that segment must respect the rule of 2/3, 60%, 38 degrees, whatever, but you need to address the right lordosis restoration in the lower lumbar spine. And single position surgery in lateral for a robust 360 fusion, focusing in safety, efficiency, and efficiency and alignment, which is critical for this. So again, thank you so much for the invitation. I'm glad to be here and open for questions and discussions. Thank you.
Thanks, Cristiano, for this phenomenal lecture. We have a lot of questions.
Cool.
We have Mike Shelby there and Alexandre Carvalho, a couple of friends. So Mike asked two questions. The first one is if you have experience doing the incision of the rectus abdominis in between the two folds of the rectus, or you always go to the left side of the rectus? And if that changed the rates of hernia?
Okay, good. Very good question. I mean, even for my supine A-lifts, if I do just 5-1, I go to the lateral border of the rectus muscle. So open the rectus shaft and just translate it. For me, it's better to achieve the retroperitoneal space, and I don't have the problems with denervation because the rectus denervation is from lateral to medial. And if you need to go 2, 3, 4 levels with A-lift, definitely you have to go from medial to lateral. But I'm showing, and we were discussing about publishing a video of this approach. I'm showing basically that it's completely possible in most of the patients to move the rectus from medial to lateral, or to keep in place and go lateral without any big challenge. For me personally, if I do just 5-1, I go lateral to the rectus, and I open the rectus shaft just in continuation with the obliquous shaft. So I have the anchorage of my points at the end easily. And we know that the hernias occur in the middle. I mean, in the pararectal, in the paramedial situation. In oblique, in the more lateral part of the abdomen, the incidence of hernias, the post-op hernias is too low. So we discussed this with many general surgeons, the wall, abdominal wall surgeons, and they all agree that this is not a big issue if you close it carefully.
Yeah, and you do the skin incision exactly the same as in a supine A-lift, or you do a more lateral incision closer to the iliac crest?
Yeah, I don't use that rule to put 2 fingers from the anterior IS, and to make the incision. I moved my incision more medial over time. So in the middle of my incision will be the rectus muscle, basically. Okay. But it's still lateral than when I do my supine A-lifts. I think that because of the gravity, the skin, the belly goes down, moves down, and the skin also. When the patient returns for the supine position, that incision stays more lateral than when you perform supine.
Good. And if you're doing an A-lift at 5'1" and a lateral at 4'5", where you start? You start with a A-lift or you start with a lateral? I know the answer, but about the relaxation and the neuromonitoring.
To be honest, there's not a rule for that. Most of my colleagues, they started with A-lift and then moved to lateral. I personally prefer to start with lateral. One, because it's a technique that I perform. I feel very safe and comfortable. I perform an X-lift in 4-5 in a little more than, the retraction time is less than 10 minutes, but the procedure itself, it spends like 20 minutes, 30 minutes at least, the most. So I prefer to start with my X-lift, do the job, and then to ask for my anesthesiologist and allow them to infuse muscle relaxants, because I need the muscle relaxants to perform the 5'1" A-lift. There are surgeons who decided to do without muscle relaxants, but I feel very comfortable with my anesthesiologist handling the peritoneal sac and with my neuromonitoring team, because I performed the 4-5. They said, oh, everything is okay. They create they check all the nerves before I started the 5'1". The 5'1" is not neuro risky, but it can happen. But when I'm finishing my discectomy and putting my cage, probably the neuromonitoring team, they're already checking the motor potentials again. And during this time, they still keep doing the SSCPs.
Got it. So Alexandria asked about deformity corrections in a single position. We all know that for a degenerative case, 5'1" and screws, it's pretty doable. But where is the limit you see for single position in deformity? How much levels or how much correction you can achieve with single position, and when you perhaps do a flip in the patient?
Alfredo, I try to do my best to be as honest as possible in this type of presentation. And I will give you an example. When I started with MIS surgery 20 years ago, 2004, I was very excited about all the possibilities. A couple of years later, I did Lenke 5 thoracolumbar myodeformity scoli in adolescent using MIS techniques, just in tubular Perk screws. It is possible? Yes, it is possible. Never did before, never did again, because it's not the best for the patient. It takes so long, the quality of the fusion is not that good, the correction is not that good, so not everything that's possible is the best. In my hands, I do up to 3 levels in single position surgery. It's possible to perform more, yes, but I don't think it's the best for the patient. If the patient needs more than a 3-level fusion, probably this patient has some deformity characteristics. Cannot be a adult scoliosis, but at least a flat back or something are going on that is not the case to keep doing this. My feeling is that this is a great technique for most of your cases. If you do degenerative spine, if you do normal mild deformities, this is the best way to do. And honestly, I do a lot of adult spine deformity, pediatric deformities as well. I know exactly how to handle this and not to have my indications, my preference over the right indications. So I believe that these are This technique is good for up to 3 levels in degenerative conditions.
Awesome. Also, Alessandri asked, I mean, there's different animals for each of these techniques. I mean, we heard a lot about comparing PSOs with ACRs, and they have different indications. You know, we're talking about fixed versus flexible deformity. So, and we have the same conversation about single position lateral versus single position prone. So where you see there's a spot for prone surgeries, because as you mentioned, there's a lot of these surgeries that are revision surgeries. They are typically 5-1 fusions, and they have an adding on, and you got to go for 5 or 3-4. So where you see prone lateral, it's superior to single position lateral, because in those cases you have to remove the screws or rods, and it's kind of tricky to do that in lateral. At least in my hands, I don't know. Maybe you're more used to that. So where are the patients where you say this is perfect for lateral, this is perfect for prone lateral?
Okay, that's a great question. I mean, I think that prone lateral is great when you have adjacent segment disease, especially after at least two level previous fusions. So an L3, L4 adjacent segment from an L4S1 fusion. So to address the 6 screws below and to put 2 extras, or to make some linkage, some extra construction, it can be tough, and it's tough, you know. And when you have a single level, for example, you have a 4-5 or a 5-1, and you want to do 4-5, it's not a big deal because you can take out the 4 screws very nicely. But I do believe that for adjacent segment in patients with previous instrumentation, I think that when you have to address a long deformity, the patient has, for example, L3S1 previous fusion and develop a scoliosis up to that fusion. It occurs, and you need to address the anterior spine. So in these cases, I perform prone lateral. I think that's awesome. Another indication, I think, in right hands, is corpectomies. Up L2, L3, L4 corpectomies, you can use prone lateral in many situations, you know. So, but what I cannot agree a lot is to gain a couple degrees in 3-4 and 4-5, for example, I will lose important degrees in 5-1, doing, for example, 3-4 and 4-5 prone lateral, and L5S1.
Yeah, I completely agree with that. Yeah,
It doesn't make any sense.
Fundamentalism of prone lateral. Yeah, I agree with that. Yeah. I agree. I also see a spot for prone lateral when you have to add direct decompression plus indirect decompression. That's a good maybe a good idea to put the prone lateral, and to add posterior osteotomies to win a little bit more lordosis in a pre-flat stenotic spaces. But most of the degenerate cases, first surgery lateral it's better in my hands. I mean, in my opinion.
As we said about ACRs, I love ACRs. ACR is a great technique. It's so sophisticated. It's so nice. You have nice implants, etc., etc., etc. But we found the right spot to indicate ACRs. ACRs are not for everyone, are not for every patient. You have specific indications for that. What I don't agree, what I disagree better than this is, you know, to say that lateral is that. Lateral and lateral is that. Now everything is prone. I mean, for me, it doesn't make a major sense for these reasons.
I agree. Alexandre also asked about
Hey, you
Roberto
need
Diaz
to
classification.
say, Alexandre, to keep calm. Otherwise, we're going to spend the entire night for questions from him.
He have very good questions. That's what I'm collecting.
He's a very
Yeah.
good. He's a very good questioner.
So he asked about Roberto Diaz, the guy from Colombia. We all know that. About the classification system for with the different anatomical shapes, to know where to when to go and when not to go to the L5S1 disc. He asked about if you use that classification and if you see value.
Yeah, definitely. Very good question. Roberto and Miguel Bebel, they have a lot of experience in terms of anterior approach, anterolateral approach, and this classification is very useful. I don't use the classification itself, but all the concepts, I totally agree with them. What I consider is that we don't need CT angiography. If you just have a good quality MRI and you scroll your mouse during different cuts from L3-4 to L5S1, you can see the level of where the vena cava, the iliac veins turn to vena cava. So you can see the anatomy, especially for the left iliac vein. If you have contraindications for anterior approach, if you have a very low bifurcation, but because it's the vein, it's not the artery, but the conjunction of the iliac veins into vena cava, it's extremely low. So you can address doing like a 4-5. I did it a couple of times, but it's more challenge. If you have large osteophytes or osteophytes, because when you have large osteophytes, it means that you have inflammation, and maybe the vein is so stressed and so it's so close to the anterior longitudinal ligament of the anterior fascia, the prevertebral fascia. So I do routinely to open this fascia and to move all the tissues with the vein and not just the vein. Third, when you don't have a layer of fat of areolar tissue behind that vessel. So this is an important tip as well. And finally, take care about TLIF revisions, because it's more complicated than you can address, you can think, because sometimes you have a lot of inflammation, a lot of the tissues are very close after a TLIF. And the last thing for me, the most complicated one is spondylolisthesis. So after infection can be horrible. You need to be careful not to have a venous lesion.
How much you push the indication? I mean, if you see all these things, you change the approach and go posterior, and that's it. I mean, or you push it and go anterior anyway.
No. I think that we are responsible for our choices, and if I can, I move for posterior. I try to do the best TLIF ever. Put in a cage very anterior, doing osteotomies in the two sides, both sides. But if the patient really needs, so I will ask for help for an experienced vascular surgeon. So we do have here in Brazil good guys, good access surgeons that not unfrequently they come to my place to help me with those approaches. So I consider that for routine cases, you can do by yourself. It's just a matter of to trespass the learning curve and to understand well the anatomy. It's easier than expected, trust me. But if I have these specific conditions, I prefer to call for help.
Awesome. And I have a question about the posterior screws. You start with the bottom screws or with the lower screws when you put in lateral position?
Nice. Using fluoroscopy, I do both at the same time. My partner goes with his left hand in the upper screws and the right side of the C-arm beam. And I stay on the left side of C-arm beam with my right hand, the lower screw. So we share the challenge. I use my right hand, but the most difficult pedicle, and he uses his left hand, but the easiest one.
Got it. So you do
But
bilateral.
when I use navigation, I prefer to start with the bottom screws because I think that the bottom screws are more challenge, and I think that I can start with the most difficult part.
Well, I heard a lot of surgeons talking about unilateral screws in single position lateral, and very well-known surgeons like Lamartina and guys that do a lot of single position surgery. And their thoughts are they are pretty similar stability with single lateral than both the bilateral pedicle screws. They're trying to prove that in with cases, but what are your thoughts about this? You always put bilateral, or if they're challenging to put the lower screws, you just do one side?
Okay, I started with single position surgery using X-Leaf and percutaneous pedicle screws in lateral position. So when I started, I think that was around 14 or 15, 2014 or 15. I started with upper pedicle screws unilateral because we know that biomechanically, if you use a standalone X-Leaf cage 22 millimeter wide, you're going to have 300% of stability of the normal segment. If you add just unilateral pedicle screw fixation, you double this to 600% stability. But if you use bilateral pedicle screw fixation, you go up to 800% stability compared to the index level. So in my hands, I use the unilateral pedicle screw fixation to learn how to do bilateral.
Got it. But if you have a choice to do
bilateral routinely,
yeah,
I left. I decided never to do it again because it's not wrong, isn't wrong, but it's ugly sometimes. It's not that good if your patient has any type of complication. For example, the patient had a pseudoarthrosis and goes to another surgeon for a visitation, for a consultation. The guy said, you know what? It failed because you're unilateral. So I prefer to avoid this type of situation nowadays.
Trash talkers. But otherwise, you think it's, for example, in a typical A-leaf F5S1, no spondy, no lysis, that it's arguable where to add posterior pedicles or do it standalone. Single side screws will be enough.
For 5.1, my tendency actually is to perform single position lateral and to put screws in all cases. I had to revise a couple of standalones, not because, people with young people without spondyes, with no contraindications for standalone. But some patients, they stay with some facet pain, and some patients develop some the superior articular process of S1. It stays not as close to L5, so it moves a little bit and makes some hinge, some conflict with L5 root. So I prefer to put screws in 5-1 doing an ALIF. So single position surgery opened my mind to do more and to get more stability without adding, time spent in the OR, need to flip the patient, and et cetera, et cetera, et cetera. So it's I don't have excuses for not adding the screws.
Yeah, I got it. So another hot topic today is the problem about having a pinching nerve with hyperlordotic cages in L5S1 to open too much anterior and closing the foraminal. Have you heard about that? Have you had cases about that, or do you think it's just a myth?
I mean, when you choose an ALIF hyperlordotic, you have to deal with a simple rule. First, you have to keep the posterior height of the cage, of the intervertebral space, with the patient's pre-op upper level. For example, if you have 8 millimeters in 4.5, or I usually keep at least 8 millimeters at the posterior part of the cage to maintain the foramen open. These for 20 and 25-degree cages. In the rare situations when I have to use 30-degree cages, it's not common. They are really ACRs done by ALIF. In this situation, I always perform bilateral foraminotomy in the back. So my routine single position cases, I use 20-degree cages in 5-1. I rarely use 12. I never use 8-degree cages. Sometimes now with the 15s, that's okay, but it depends on the patient's anatomy. So my routine is to use the 20-degree cages in 5-1, and no problems with the posterior height if you choose 8 millimeters in the back. But if I need the 30-degree cages, so I will open that foramen, because otherwise these translation of the superior articular process
is risky.
Can be bad.
Yeah, Mike, are you there? You have a question? It's Mike Sellers from Australia.
Hey, Cristiano, that was a great talk. I think, look, I do a lot of prone lateral surgery. I do ATP sometimes, but I still do a lot of supine ALIF, because I'm using a lot of hyperlordotic cages, and I take down the PLL routinely. And I realized a couple of years back that not taking down the PLL had caused some of this impingement. And I find that when you do like an ACDF approach, particularly at 5-1, completely take down the PLL, you can take off some posterior osteophyte, you'd never get this impingement, because you get better posterior height restoration without risking end plate subsidence. So it's meant that I've been a bit lazy on learning lateral ALIF. I certainly think it's a great technique. But just that my workhorse for deformity has been to take the PLL. Do you have any tricks for doing this? I've always thought about, in the lateral position, sticking the scope in to take it down, because obviously you can't see it straight on like we can in a supine ALIF. So have you experimented with ways of PLL takedown in the lateral position, would be my question.
Oh, great. Thanks, Mike, for the great question. It's extremely important. First of all, I will return with my slide that I mentioned, that indication for lateral ALIF, you have to avoid extremely high PI patients, because otherwise you cannot see, you cannot address the posterior part of the disc and the PLL. You cannot see it, so you cannot perform this type of thing for sure. But once the patient has not a PI over 75, 80 degrees, you can reach the posterior longitudinal ligament. You can open with your Carrison. You can use different instruments. In my routine, I don't open the PLL in all patients, because I just open the PLL when I have a free fragment of the disc that I have to capture from anterior. What I do is use curettes to release the PLL from the vertebral body edges. So I do this in the posterior way. I pass my curettes in the posterior part of L5, the posterior part of S1, and I'm done. When I have a very critical collapse, disc collapse, I use some scrapers like we use in TLIF, and I put them very posterior, very close to the spinal canal, and I scratch a little bit to release, especially at the beginning of the disc distraction. Then I move to my curettes. Then I can address and I can gain height step by step, not overloading the end plates, to finally reach the decompression I need. So I completely agree with you. Supine ALIF is a fantastic technique, but when I have some challenge situations, as I mentioned, I decided to move to supine. I do my supine ALIFs as well, but in the most of my patients, I can address 5-1 and lateral. And to be honest, nowadays I feel more comfortable to do the approach in 5-1 using lateral ALIF than using supine ALIF.
Well, awesome. We're in time. Thanks again, Cristiano, for being so kind. It was a very meaningful session. So we're open to questions. In a couple of days, maybe 2 or 3 days, this session will be recorded in YouTube for all you guys you want to go over this again. So thanks again, Cristiano. It was a phenomenal lecture. You can close this session with your words.
Okay, thank you, Alfredo. Thank you all, and have you all a good evening. Bye.